societies, it's the number one son or his wife, or the only one in the family that might speak English, whoever that may be. Sometimes that's the grandchild, you know, a teenage grandchild. And in that case where the child the person who's translating is a minor, we try to get hired interpreter because there are legal considerations. And also it's not fair to involve the teenage child to tell him that his grandmother is dying. That's very frightening for the teenage child translator, you know, because it's very hard for him to say that,
right?
Because he doesn't have the emotional maturity. So for those where we realize that we're really limited by that, we try to make an appointment where we can really hire a translator, you know, a professional translator, bring them in, bring an appointment, you know, after hours, after clinic hours, or at a time when everybody can show up.
I would think sometimes that life and death decision would have to be made that minor children or minors could not really do, so you would have to have, you know, additional help.
So you would need an adult translator and some adult family member who can really take charge.
So how do you view the distribution of medicine and the new techniques affecting this cultural divide? Because, you know, with new services, MRI, CT scan, how does that translate to different cultures?
I think that most cultures view non-invasive procedures okay. If there's no needle, no anesthesia, they're pretty much okay with it. It's just that when we say, oh, we want to do a biopsy, which is invasive, that they may be afraid. You know, that's when the fear comes in. And some cultures, they're just afraid of needles because they think that's invasive, and that regardless of what we say, they think that you're putting something in them rather than you're drawing out blood. And there's been the history of some distrust, certainly in informed consent. In the Native American population in the 1960s and 70s, there were forced sterilization of Native American women without informed consent. And that really was horrifying to the Native American community. And to this day, many of them will not go to the Indian Health Service doctors. So many Native Americans will go outside of their reservation and seek care outside because they feel that it was the Indian Health Service that perpetrated that. So even though they had intentions of telling them, well, they were pregnant at age 14 and now they're back, at that time it was cultural insensitivity because those doctors will say, well, you just can't have 10 babies by the time, you know, you're age 20. But it was their culture for them to be fertile. And once these 18-year-old women had their tubes tied, to their culture they were considered to be pariahs because they could no longer bear children should they get married in a proper tribal ceremony. So there's a lot of distrust still today that exists in certain cultures in America.
So in this case, the medical system did not serve the cultural underpinning of that society.
At all.
At all.
Right.
So it was very distrustful, and I don't know that it ever can be bridged again, but it certainly needs to be done. So amongst different cultures, you would have different ways of bridging that, and the law helps in that case, correct?
Yes.
Okay.
Yeah, I think one of the issues that this has played a role in cross-cultural considerations, when we look now at 2010, looking back, there have been some very bad things that we did in America, you know, in the sense of informed consent. We just said, sign here, and we didn't really tell these people who didn't speak the language what was going on. And it's only afterwards, now that we have this understanding that, you know, informed consent exists, that, you know, things have changed.
So the whole premise of cultural consideration in medicine and delivery of medicine has to do with sensitivity to the individual, sensitivity to the culture, and the ability to translate that need into that person's environment.
Yes.
So I would think this is a big job to be not only the delivery of medicine, but the delivery of the translation for acceptability to the patient would be a big issue.
Oh, definitely. It's going here to stay.
It's here to stay. What other areas do you find that cultural differences really impinge on the delivery of medicine?
You know, you mentioned ageism, and I think that's one of the things that people forget about. And I think that because so many times in a doctor's office, it is indeed the elderly that seek care because they now are sick for the first time. And we forget that even though they're fluent in English, they grew up here, that they may not understand the necessity for having a pill being taken exactly the same time every day. They may think once a day means, well, I'll take it at 7 o'clock on Monday, but 3 o'clock on Tuesday, and I'll just skip Wednesday, and then Thursday I'll take 2, you know, to make up for it. And I think we need to make people aware of that. And as a doctor, any doctor will know, many doctors, many patients will come in and says, oh, I take a blue pill, a pink pill, and I don't know the names. So it's very common for patients to see a new doctor and have a new problem, but not know their medicine, and they don't know enough to bring a list of medicines. So that's very hard for the new doctor taking over their care. Or in my case as an ophthalmologist, many of the medicines they take for their heart or for their cholesterol impinges on what happens to their eye. So again, that's the ability to understand what is modern medicine like now, and health literacy. So that's sort of letting an elderly person know that, you know, when you go drive your car, you have to carry your driver's license. So when you come to a doctor's office, you should really, you know, bring a list of medications.
Well, thank you, Dr. Wu. I would like to thank you for joining us today, and I would like to thank Dr. Wu for this very lively discussion. And if you are interested in contributing to KSAW, please do so, and thank you again.